Barrett's esophagus is an GIT disorder in which the squamous epithelium of the esophagus is changed into the columnar epithelium, which is normally present in the intestine. And this process occurs by metaplasia, the conversion of one type of the epithelium into another type of epithelium. It is a pre-malignant condition and the complication of the gastroesophageal reflux disease or GERD. The risk factors include men. It is most common in the men and it is most common in the white people than black people. It most commonly occurs after the age of 50 and it is weakly associated with the smoking, and there is no association of Barrett's esophagus with alcohol. It is of two types depending on the length of the columnar epithelium or metaplasia occurred in the esophagus from GE junction or gastroesophageal junction. If the length of the metaplasia is less than 3 cm, it is called short segment, and if it is more than 3 cm, it is called long segment Barrett's esophagus. Long segment is the classical type. The clinical features include heartburn, which is due to acid reflux in the esophagus from stomach, or chest pain, which is like angina, and it is most commonly because of the acid reflux, and it is most commonly on the left side. Diagnosis include endoscopy with biopsy, in which you can see the intestinal mucosa in the esophagus. Normally, the esophagus epithelium is pale pink in the color, but in Barrett's esophagus, it is red velvety or salmon color. Salmon is a fish. Microscopy, you see mucin secreting glands, and the goblet cells are the hallmark of the Barrett's esophagus, which is because of the glands are normally present in the intestinal mucosa. And as the metaplasia has occurred and the intestinal epithelium is now in the esophagus, so the goblet cells are present there, and these are the hallmarks. The management includes 3 types. If the Barrett esophagus is without dysplasia, if there is no dysplasia, then we will give the PPI such as omeprazole and do endoscopy every 2 to 3 years. If there is low-grade dysplasia, we will give PPI and do endoscopy every 6 to 12 months to see if this has changed or is there any risk of developing the cancer. And then the high-grade dysplasia, in which the esophagectomy or surgical resection of the affected part is done. According to the current definition, there are 2 conditions that has to be present so we can label a disease as the Barrett's esophagus. This include endoscopic visible columnar metaplasia, irrespective of the length. Doesn't matter if it is small or large or more than 3 cm or less than 3 cm, but there will be the columnar metaplasia. And on histology, we see the goblet cells which give an indication of the intestinal mucosa. So these 2 have to be present there to label this disease as Barrett's esophagus. The complications include most commonly ulceration with the stricture formation, and it can also pose the risk of the adenocarcinoma, which is less in the short segment but 30 to 40 fold in the long segment.